So welcome. We're joined here by Dr. Humphries from UC Davis and Dr. Wooster from MUSC, South Carolina, to discuss the L6, which is a new Shockwave lithotripsy device for use in large vessel access. Just to start off, would Dr. Humphries direct to you first. How has this device sort of changed your practice and your approach in treating larger vessels?
I really like the L6 device. When the first M5 device came out, the first thing I said was, I need a bigger one for the iliacs. And my rep was like, oh, you'll be fine. Just use the largest M5. And now they've come out with the L6. So it really opens up the ability to do thoracic endografting and aortic endografting for patients with calcified vessels.
Dr. Wooster, I'll direct that same question to you. Any insight?
Yeah, so very similarly, the M5 worked. It was a great device, but this simplifies the procedure. Instead of having to use a small Shockwave balloon that's truly undersized and then come back with a standard balloon in order to get up to a large enough diameter for our large bore devices, you do it in one step, and it just makes things much more efficient.
So this naturally lends itself into discussing some cases. So Dr. Wooster, we're going to have you start.
Sure. So this first patient that I'm going to show you is a little bit atypical of a case, but a really nice example, I think, of how the L6 can really impact our care and change the pathways that we have available to us. So this is a 70-year-old gentleman who is in an assisted living facility and presented with sort of subacute critical limb ischemia, kind of a 2A, almost 2B picture, but relatively functional at baseline, but not the healthiest gentleman. He had urinary incontinence, fairly obese. He'd had some prior surgeries that he was unclear about, that he said maybe a prior aortic stent of some sort for ischemia in the past. Came in pretty tachycardic, hypoalbuminemia, just not a patient you really want to operate on if we could avoid it, or at least not surgically operate on him. What you see is we're a little surprised by what had actually occurred in the past. He had about a 5-centimeter juxtarenal aortic aneurysm with thrombosed what appears to be a migrated iliac stent. It looks like he had a probably left common iliac artery stent that, with the deformation of the aorta over time from growth, probably migrated up into the aorta and is now encapsulated by mural thrombus. And then if you focus on the bottom right of the screen, you'll see a nearly occluded, very heavily calcified common femoral artery on the side that he's presenting with this subacute ischemia. And so a lot of different approaches to it. And I mean, maybe I'd ask you guys how you would tackle something like this. You have a juxtarenal 5-centimeter aneurysm and a subacute ischemia with a nearly occluded common femoral.
Just the kind of case you want to tackle, right, Dr. Humphries?
Always, nothing is simple these days. I mean, for me, whenever I have lesions in the common femoral endarterectomy, but this patient is got bad disease, a lot of other things going on. So do I want to do a femoral endarterectomy in somebody who there's a good chance there might get an infection in the groin? No, I'd much rather go through a percutaneous option.
Yeah, so that was our thought. I think at this point we didn't even have a UA back yet, but we were suspecting that he had likely urine infections since he'd had them in the past. He had hyponatremia to go along with this as well. And so we wanted to avoid prosthetic. We wanted to avoid making an incision in a groin that was very likely to have a lymphatic leak. So what we did is we approached it percutaneously to start. We accessed that common femoral above the occluded segment, knowing that we'd come back later. And so we started perc. We pre-closed both sides. We can go on. You can see the occlusion on the left-hand side and the right. We got up both sides, protected them with standard balloons because the upper portion was not calcified at all, which created a pathway to get our endograft up to prevent embolization in the past. Relatively standard infrarenal EVAR endo anchors, just since we had a very short neck and a gentleman who was fairly unreliable, likely to not show back up. And then you can see what our access looks like at the end. And so you take these pictures just beyond our per close, you can see basically occluded common femoral distal to it. And so at this point, we went ahead and closed that left-hand side, came up and over from the contralateral, and we were able to get an 018 wire past the nearly occluded segment fairly readily. Had some concerns about our trackability here. This was actually my first L6 case, and I had a little concern coming up and over a flow divider or an endograft if it was going to kick my sheath back, but surprisingly tracked just beautifully, had no kickback at all. We performed 2, maybe it was 3 rounds of lithotripsy, had complete expansion of the L6 balloon. I forget if we followed up with a DCB behind it, but if you look at the result there, really it looks like an almost pristine common femoral artery.
Yeah, it's a nice
I
result.
think Dr. Humphries, just from your head nod, I see you approve.
Well, I think what was interesting about this case is, the trackability. Because when you're coming up and over a flow divider, when you're going, through an endograft, that's challenging. That's challenging for simple balloons, and for a lithotripsy balloon, which has a little bit bigger profile, I'm impressed that it could do that. So that's one of the great things about it.
Yeah, I was very surprised. I think that the shorter length of the balloon actually helps with that. I think it's a little bit less to track, and I suspect that's one of the reasons it was so beneficial. The shaft of the balloon, they made a little stiffer than the M5 was.
Plus, I think it's the 018 wire versus the 014 wire.
Would you think about going and doing the lithotripsy before? Because of the concern for being able to track over the flow divider. So what made you think, I'm just going to do this after?
Yeah, that's a good question. So we thought about it. The initial thought of why we didn't want to do it before was, first we had to get through an occluded iliac, make sure the iliac stayed open. And so I didn't really want to have to work through a freshly ballooned common iliac without stenting it and then come back and put an iliac limb inside of the stent. And so I really wanted to just do it in one step. The second thought was we still had the option of either doing a femoral cut down or doing a percutaneous peel stick if we had to, if we couldn't track up and over the flow divider. And so I figured we had some bailout options if it didn't play out.
So was the SFA occluded or was it open?
SFA, I believe, was... I don't remember.
Okay.
I don't remember.
Suffice it to say, if you just got enough inflow to get them out of Dodge. Any following up with Dr. Humphries' question, oftentimes I will pre-dilate the lesion. I don't know if you have anything to add to that. I will oftentimes take a smaller balloon, maybe pre-dilate the lesion to deliver the...
I've probably done that 2 or 3 times, maybe. I prefer not to. For me, it's an extra step.
Yeah.
And this is not like atherectomy, where I have to make sure that the burr can track through or that the device can open up initially. The shoulders and the profile on this, when I first started using Shockwave, back to the initial M5, that was my worry, was that I wouldn't be able to track because I had to go down to an 014 wire. And I've been amazed that, generally speaking, I don't have to pre-dilate.
Yeah, with the L6, I haven't had an issue with trackability. I do a lot of tibial work, so when you're thinking about the S4 and very small tibials, that's a place where I frequently have to pre-dilate because I want that device down there because I want to change the nature of the vessel itself with lithotripsy. But in this device, it really works well, and not a lot of issues with having to go through these tight lesions where I couldn't get the device to track.
Yeah, I agree. I think it's just something about this. The trackability is better. And I think the 018 wire adds that sturdier platform, if you will. I mean, the fact that you got this through an 014 and a heavily calcified lesion is...
over a flow divider.
Over a flow divider.
Hey, I was surprised. I was fully expecting to fail, and
we would expect nothing less.
It worked out nicely. So
well executed.